are doing this webinar we are conducting as part of MissionBrain India Chapter. What happened exactly, how we started was like a month ago, our team decided to become part of this internationally renowned organization called MissionBrain. And what about this is that I don't know if you guys have seen the series on Netflix called The Surgeon's Cut. There is this second episode I very vividly remember. It is of Dr. Quinones. He is the head of neurosurgery at Mayo Clinic, and he's also the founder of Mission Brain organization. This currently has many avenues like humanitarian, academic, and research work. And honestly, we just felt like it was the perfect platform to join. Of course, not just for the sake of CVs, but because again, it is also a very nice thing to have a team, and it just makes things nicer going through this clinical journey. And yes, I wanted to say that we are very lucky and fortunate to have Dr. Siddhartha sir, who has been very thoroughly supportive of us, and he has encouraged us to make this event possible. And honestly, not just this event, I think he also laid a very good stepping stone for all of our future initiatives. And yeah, before we dive into the clinical side, I'd like you to meet the rest of the team. And so, yeah, guys, just turn on your mics and introduce yourselves.
Good evening, sir. Good evening, everybody. This is Shraddha Lal, a final year MBBS student at Osmania Medical College. I'm today very much delighted to be a part of this team, and I would like to extend my gratitude to Dr. Siddhartha, sir, for being part of our team and helping us in organizing this webinar today. Thank you so much, sir.
Uh, Thank you. Thank you all. Not an issue. You can continue with your introduction part. Then I'll talk.
Yes, sir. Good evening, everybody. I am Amrita Priya, a final year MBBS student from Osmania Medical College. This being a very first event, I am excited and I'm very grateful for having so many participants and especially grateful to Siddhartha sir. I'm hoping this will be a successful webinar.
Shall we start off then? If others are not talking or introducing themselves. Hello. Hello.
Yeah, sir, we can start off.
Am I audible first of all?
Yes, sir.
Yes, sir.
Okay. Right. A very good evening to all of you. Those who have come up on the Saturday evening on a weekend to join this webinar. First of all, at the outset, I would like to congratulate Mission Brain India, the organizers, for coming up with a very important academic-oriented activity. I hope your organization goes leaps and bounds. And this being the first academic event, I would like to congratulate each one of you who have put an effort to come up with this event. I'm also equally excited to be part of this. Any event that shares knowledge is a good platform. I work as associate professor of pediatrics at Nilafar Children's Hospital, and we chose this topic because this is a pretty common. These URIs, upper respiratory infections and lower respiratory infections, are common in day-to-day life, where the attenders approach you, and one should have a clear idea of how to treat these manifestations, whether it be a URI, LRI. And today in this class, we'll try to learn how to differentiate between a upper respiratory infection and a lower respiratory infection, how to differentiate between whether it's a viral infection, it's a bacterial infection, and what's the treatment and the further management of these illnesses. As I said, upper respiratory infections are pretty common. They are mostly seasonal. They occur with equal frequency in both males and females. And one should remember that every child will have at least 5 to 6 episodes of an upper respiratory infection and 1 or 2 lower respiratory infections in a year. And if vaccinated, if appropriately vaccinated. So we'll talk about what are the various upper respiratory infections, followed by a brief introduction to a lower respiratory infection, because lower respiratory infection itself is a big chapter. I think we need 2 or 3 classes for lower respiratory infection, including both parenchymal illnesses and airway diseases. So uh, in this upper respiratory tract infections or today's talk, I'll deal about rhinosinusitis, pharyngitis, otitis media, croup, epiglottitis, bacterial tracheitis, tonsillitis, and adenitis. Next slide, please. So etiology, most of the time it's a viral etiology, and most common viruses include rhinoviruses, respiratory syncytial viruses, influenza, parainfluenza, non-polio enteroviruses, coccidioviruses. Bacterial, most common include group A beta hemolytic streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, and Staph aureus as well. So can anyone type in the chat box, or can anyone tell what is the difference between common cold and flu? Anyone? What is the difference between a common cold and flu? Did anyone experience a common cold? Did anyone experience flu? You can share in the chat box. So acute rhinosinusitis is the common cold that we encounter. It is generally a viral infection, and children below 5 years generally have 5 to 8 episodes per year. As I said, acute rhinosinusitis or cold can present with a systemic features, like it can present with a fever, it can present with a rash, associated with a running nose, a congestion of the nose, and it may be associated with a scratchy or irritative throat, cough, and conjunctivitis. So the differentiation between flu is severe than common cold. Yeah. It is not the severity, but it is the systemic. It is the systemic involvement which is more prominent in flu. Flu also is associated with a high grade fever, myalgias, and more, as you said, more duration of illness. Rhinosinusitis is generally associated with conjunctivitis, and most of the time it's restricted to the upper respiratory tract. It doesn't have myalgias. It doesn't have a very severe fever. Yeah, high fatigue influenza, high fatigue. It's right. You are right. One should try to differentiate between flu and rhinosinusitis. Flu generally is confined to fever, followed by headache, myalgias, whereas in rhinosinusitis, it is the congestion, the irritation of the throat, the cough, which is more prominent, and which has a less severity of fever. So, as most of us experience common cold, there is no need for any antibiotics. we should treat it symptomatically. Apart from rhinosinusitis, which is a common cause for cold, or the viral infections, which are the common cause for the cold, can anyone tell what are the other differential diagnoses for rhinosinusitis? Or you can type in the chat box. What are the differential diagnoses for common cold or the rhinitis or rhinosinusitis? Where you get rhinorrhea, allergic rhinitis, right? Other than that, so when you have a rhinorrhea condition, sore throat, pharyngitis, it's not. It is what you can say is, yeah, pharyngitis is also right. Other than that, one should also always remember that a unilateral foreign body can produce a rhinorrhea. It can produce congestion. Any mass in the upper respiratory tract can produce a rhinosinusitis. Rhinitis medicamentosa, which is due to usage of decongestions, is another DD. And it can also be due to nasopharyngeal carcinoma, and it can also be due to some other drugs. So what is the treatment of acute rhinosinusitis? There is no specific treatment. It is only symptomatic treatment. One should use steam inhalation. One can decongestions and cough syrups are to be avoided in less than 6 years children, or rather less than 5 years children. Those can be used only in children above 5 years. It is only a symptomatic treatment. It persists for 5 to 7 days, and generally in around 7 to 10 days it resolves. So one should remember the differential diagnosis of acute rhinosinusitis. Most common being allergic rhinitis, where there is no fever. In acute rhinosinusitis, there can be fever, but in allergic rhinitis, there is no fever, and suspicion of foreign body should always be present. Next slide. Then we'll go on to a case. This is a 3-year-old child presented with complaints of fever, difficulty in swallowing, and drooling of saliva. On examination, the child is toxic with a temperature of 1 or 2 and prefers sitting in leaning forward position. Any differential diagnosis, please? 3 years. Look into the age and the presentation. There is difficulty in swallowing and drooling of saliva. On examination, there is fever, and the child prefers to sit in a leaning forward position. Child is toxic. Foreign body, generally the child doesn't have fever. Child is not toxic. Diphtheria, drooling of saliva, yeah, diphtheria. Apart from that, child is preferring to sit in a leaning forward position. Croup, yeah, what is the telltale sign of croup? Sinusitis? No. Okay, so here the child prefers to sit in a leaning forward position, which means the child is trying to ease on a upper respiratory obstruction that is going on. So this is a case of epiglottitis. Most of the time it is due to bacterial origin, and the most common organism implicated is Haemophilus influenza. The child is febrile, toxic, and has drooling of saliva and difficulty in swallowing. There is airway obstruction, upper airway obstruction, mild upper airway obstruction. There is edema of the vocal cords and obstruction at the level of the vocal cords, at the level of epiglottis. So how do you treat this child? Treatment of this child, as we said, the most common cause is Haemophilus influenza. One can give oral amoxiclav 40 mg per kg per day for 10 days. Here you can see the thumbprint sign, where there is airway narrowing of the airway, upper airway. Generally, the course of amoxiclav for 40 mg per kg for 10 days is enough. And if the child is sick enough and is unable to take orally, we can go with intravenous ceftriaxone or cefotaxime for a period of 5 to 7 days. Next slide, please. This is a 2-year-old child brought to the OPD with complaints of fever, cough, noisy breathing, and change in voice. On examination, the child has stridor and suprasternal retraction. Any differential diagnosis for this case? There is fever, noisy breathing. That noisy breathing is in the form of stridor, and there is suprasternal retraction. Pneumonia, here we see on clinical examination there is suprasternal retraction. Yeah, someone has written croup. Yes. So this is a case of laryngotracheal bronchitis, which is called croup. There's a triad: barking, cough, stridor, and suprasternal retraction. This is an upper respiratory infection where there is laryngotracheal bronchitis. There is narrowing of airways leading to cough and stridor and suprasternal retraction. Most common etiology is viral etiology. It could be parainfluenza, influenza, and respiratory syncytial viruses. So how do we treat this laryngotracheal bronchitis or croup? It is a symptomatic treatment. If the child is not sick enough, one should use steam inhalation, and for mild, for fever, you can use antipyretics. And if the saturations are low, and if required, humidified oxygen. The saturations are less than 94 or 92, one can start off with oxygen. The child is not improving with the above treatment, one can give nebulization. Depending on age, we can give budesonide nebulization, which is a steroid. For under 3 years, it's 1 mg 12th hourly, and over 3 years, 2 mg 12th hourly. One can also use adrenaline 1 in 10,000 dilution 1. For 2 to 3 years, it's 0.25 ml of adrenaline with normal saline, and over 3 years, it's 0.5 adrenaline with normal saline. And if even after two or three doses of adrenaline nebulization, if the child is not improving, one can go with a oral steroid or a parenteral steroid. Parenteral steroid is preferred here, 0.3 to 0.6 mg per kg single dose. And most of the time, the child will improve. So in croup, there is narrowing of the upper airways, called as steeple sign. So no need of any antibiotics. One can use a symptomatic treatment. Initially, steam antipyretics and humidified oxygen. If not improving with these above measures, we can use nebulization with either steroid or adrenaline. If not improving, one can go with the parenteral steroid or oral prednisolone 1 to 10 mg per kg for 3 days. Next slide, please. So following URI or following a croup or epiglottitis, there can be a secondary bacterial infection wherein the child is almost recovering, but the child again becomes febrile, toxic, and a severe stridor is present. This indicates that this indicates the child is secondary infected with a bacterial infection leading to a bacterial tracheitis. This generally occurs 4 to 5 days after a viral URI or after 4 to 5 days of a epiglottitis. The causative organisms include a Staph aureus, Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis. How to identify bacterial tracheitis? Generally, it occurs after a period of 4 to 5 days. There is history of prior upper respiratory infection prior to this. What happens? The child is very afraid, very irritable, and has difficulty in coughing, and in fact is afraid to cough. If you take an X-ray, the child X-ray shows irregular tracheal borders with edema, which is called candle dripping sign. How do you treat this? You can treat with cloxacillin with an aminoglycoside or a cefuroxime with vancomycin. This is the candle dripping sign with irregular margins of the airways. Next slide. This is a 7-year-old child brought to the OPD with features of high-grade fever, sore throat, and pain during swallowing. On examination, there is pharyngeal and tonsillar excretes, palatal petechiae, and tender upper cervical lymph nodes. I think this is an important case. Try to remember this case, and you can see the picture here. Next slide. Can anyone tell what is this? With the clinical features of high-grade fever, sore throat, and pain during swallowing, and examination findings being pharyngeal and tonsillar exudates, palatal petechiae, and tender cervical lymph nodes. Diphtheria. What is the color of the membrane? And Yeah, pharyngotonsillitis, right? Bacterial tonsillitis. Okay. So this is a case of pharyngotonsillitis. What is important here is how to differentiate between a case of viral and bacterial pharyngitis. In viral pharyngitis, the child is not so sick looking, whereas in bacterial pharyngitis, there is high grade fever and the child is sick looking. Generally, the viral illness is associated with a prodrome, right? Cough, cold, and hoarse voice. And in bacterial pharyngitis, pharyngotonsillitis, there is no cough, cold, or hoarse voice. There is maybe congestion of eyes, and then other systems are involved in a viral infection, which is not so prominent in bacterial infections. There is a history of family history members being been affected in viral illness, which is not in the case of a bacterial infection. Tonsillar exudates are present in a case of a bacterial pharyngotonsillitis, which is not the case with a viral illness. And then this tender cervical lymphadenopathy in case of bacterial involvement, and there are ulcers in a viral infection. So most of the time, the patient with a bacterial pharyngitis or pharyngotonsillitis is very sick, with cough, cold not being so severe, and no other system involved. In case of viral illness, the fever is not so high, but there is a prodrome with watering of eyes, and other family members been affected, and there are no tonsillar exudates. Go to the slide before that, before the picture. Yeah, here you can see the exudates on the left side, and the only congestion and political petechiae and ulcers in the viral infection on the right side. So this is a case of uh, pharyngitis, and one should always start off antibiotics in case of pharyngitis if you are suspecting a bacterial infection. Viral infection, very there is no need of any antibiotics or antivirals. Only exceptions being if you are suspecting a EBV or CMV infection. Epstein-Barr virus, mononucleosis-like syndrome can present like this with pharyngitis, periorbital edema, and hepatosplenomegaly, but the duration is very long, like 7 to 14 days. The pharyngitis persists for 7 to 14 days. In a bacterial infection, you see the tonsillar exudates, you see the anterior pillar is congested, there are no ulcers, the child is sick looking. Then one should start off an antibiotic in case of a bacterial pharyngitis. What is the role of antibiotics in pharyngitis? They reduce the duration of symptoms. They prevent rheumatic fever when given within 9 days of the onset of these symptoms. However, this does not prevent post-streptococcal glomerulonephritis. As I said, infectious mononucleosis should always be kept in mind, which is a systemic involvement where there is hepatosplenomegaly, periorbital edema, and a severe pharyngitis. So when to start off antibiotics in case of a pharyngitis? There's a criteria, McKesson criteria, or a modified Centaur score, wherein a score of more than 4 indicates antibiotic need. If less than 4, you should not start an antibiotic. If the score is more than 4, you should start off an antibiotic depending on the organism you're suspecting. And here we see there is each point awarded to the criteria: age 3 to 14 years, tonsillar exudate, tender swollen lymph, lateral cervical lymph nodes, temperature, and absence of cough. That if the score is more than 4, one should start off an antibiotic. If the score is less than 4 and you still have a strong suspicion for bacterial pharyngitis, one should do a rapid antigen streptococcal test, which is a diagnostic test. If the test comes positive, then you can start off an antibiotic. So more than 4, start off an antibiotic. Less than 4, with strong suspicion of bacterial infection, do a rapid antigen test. If it is positive, start off an antibiotic. So what are the antibiotics that are used? Most commonly, one requires only amoxicillin with amoxicillin 20 to 40 mg per kg for a period of 10 days. If not resolving within 42 to 78 hours, one can start off amoxiclav at a dose of 30 to 40 mg per kg. And still, if the child is not improving, one can go with a cephalosporin. Next slide, please. Recurrent pharyngitis, it is a repeated episode of pharyngitis following group A beta hemolytic streptococcal infection. It can be due to inadequate therapy or acquisition of new infection from contactor community, or it could be another intercurrent viral pharyngitis. Treatment, we can use amoxiclav, clindamycin, benzathine penicillin, rifampicin. Rifampicin is used in the last 4 days of therapy, like if you're giving for 10 days course of therapy for recurrent pharyngitis, it is started from 6th day of therapy to 10th day of therapy. This rifampicin prevents the carrier state, which leads to a chronic pharyngitis. Coming to case 4, 6-year-old male child is brought to OPD with complaints of fever, headache, and thick nasal discharge. On examination, the child is febrile and mild tenderness in the frontal region and pleural and discharge in the nasal cavity. So 6-year child, more than 5 years, 6 years, fever, headache. Here we see the prominent headache and thick nasal discharge. Any differential diagnosis? Type in the chat box. Frontal sinusitis, bacterial sinusitis, foreign body. Okay. Inka? So fever, headache, and nasal discharge. Because this is not a. I mean, we are not sure whether this child is immunocompromised child. It could be a foreign body. It could be a sinusitis. Right. So this is a case of sinusitis. But again, one needs to differentiate whether it is a bacterial sinusitis or a viral sinusitis. Generally, as we talked previously, any bacterial sinusitis, any bacterial infection, the child is very sick, has high-grade fever, myalgia, very high-grade fever, and sick looking. The thick nasal discharge indicates towards a bacterial sinusitis. And as we also discussed, generally viral infections are associated with other prodromal symptoms like a venous event rash, a conjunctivitis, and a congestion of the nose. So how to diagnose a bacterial sinusitis? If there was a upper respiratory infection and the symptoms are not improving for 10 days, then one can suspect a bacterial sinusitis. Worsening stage, the child initially improves, but again there's worsening of symptoms after initial resolution. And severity, if the child has very high grade fever of more than 1 or 2 degrees Fahrenheit with a pleural and discharge for more than 3 to 4 days, one can confirm that it is a bacterial sinusitis. So how to treat bacterial sinusitis? So depending on the severity, one can use from the mild, moderate, severe. One can use amoxicillin at the dose of 50 mg per kg in 2 or 3 divided doses. And if the disease is severe, one can use amoxiclav, cefuroxime, ceftriaxone, or injection ceftriaxone depending on the clinical situation. Duration of antibiotics is 7 to 10 days or 10 days or 7 days after the resolution of symptoms. One should remember that high doses are generally not needed for bacterial sinusitis unless it is a drug-resistant streptococcal isolates. Next case. So this is a 3-year-old child presented with high-grade fever, irritability, ear pain, and disturbed sleep for 3 days. On examination, child is febrile, ear sign is positive, and a tympanic membrane is bulging on both sides, and there is loss of landmarks. Yes, it is otitis media, acute otitis media. So how do you define acute otitis media? Acute otitis media is defined as moderate to severe bulging of tympanic membrane, new onset of otorrhea not due to otitis externa, and mild bulging of tympanic membrane and recent arrhythmia or ear pain. So what are the factors determining antibiotic therapy? So it is most of the time a viral illness can lead to acute otitis media, but there are situations or conditions where you need an antibiotic therapy. This criteria is called ALS criteria. A stands for age, less than 6 months, 6 months to 2 years, and more than 2 years. Lateralization, it could be unilateral, bilateral, and severity. Severity is defined by high-grade fever, severe otalgia, and otalgia persisting for more than 48 hours. So depending on ALS criteria, antibiotics should be started. Antibiotics should definitely be started in any child with otorrhea, a severe disease. Severe disease is defined by fever of more than 39 degrees, severe otalgia, and otalgia persisting for more than 48 hours. Acute otitis media in children below 6 months, definitely indicated antibiotic. Bilateral otitis media, antibiotics definitely indicated. And failure to improve with conservative management after 48 to 72 hours. And if the child is 6 months to 2 years and it's non-severe unilateral, still you should start off an antibiotic and more than 2 years, if it is a bilateral otitis media, you should start off an antibiotic. Antibiotic therapy, once you start off with amoxicillin, followed by, if not improving, amoxiclav and a parental ceftriaxone injections. Amoxicillin at the dose of 50 mg per kg in 2 or 3 water doses for non-severe disease. Amoxiclav at the dose of 40 mg per kg in 2 divided doses. If amoxiclav should be used, also be used if there was any other drug, any other antibiotic been used in last 1 month. It is the first line of drug for severe illness. And if there is a history of concurrent mucopurulent conjunctivitis, and if there is think that it is a recurrent or persistent otitis media, then you should start off amoxiclav as the first line of treatment. Amoxicillin is used as first line only in non-severe disease. For severe disease and with the child being showing a mucopurulent conjunctivitis and a recurrent otitis media, amoxiclav is the first line of drug. Injection ceftriaxone, a single dose with a child who is having a poor oral intake or is having a persistent vomiting. So what is the duration? For children below 2 years or children with severe disease, the duration is 10 days. And for mild to moderate disease, the children aged between 2 to 5 years, it's 7 days. And mild to moderate disease in children more than 5 years, the duration is 5 days. It is important to remember the duration of treatment, because in non-severe disease, the duration is less, and below 2 years and the severe disease, the duration is 10 to 14 days. What is recurrent otitis media? At least 3 episodes of otitis media in a period of 6 months, or 4 or more episodes in a period of 12 months. We can give antibiotic prophylaxis. It can be amoxicillin or amoxiclav. The goal is to reduce the recurrence of the otitis media. There is no accepted regime for duration of treatment, but generally a period of 2 to 3 weeks is accepted. Next case, it's a 5-year-old child came to OPD with complaints of fever, difficulty in swallowing, ear pain, sore throat, bad breath. On examination, both tonsils are enlarged, multiple exudates on the tonsils, and tender cervical lymph nodes. So one can see pus points, both tonsils are enlarged, multiple pus exudates, tender cervical lymph nodes. Tonsillitis, right? This is tonsillitis. This is acute tonsillitis. Bacterial tonsillitis, yes. Acute bacterial tonsillitis. This case, or as we have seen previously, pharyngotonsillitis, the treatment is same, unless it is a chronic tonsillitis. One needs to go for a surgical intervention. So this is the case of acute tonsillitis. Most common etiology been streptococcal pharyngitis or pharyngotonsillitis. The treatment is same. Chronic tonsillitis, there is various degrees of tonsillar enlargement with congestion of anterior pillars and then enlarged non-tender jugular diagnostic lymph nodes. This is the differentiation point between the acute phase. In acute phase, generally the lymph nodes are tender and enlarged, but here the enlarged but non-tender. So these are indications for tonsillectomy. I will not go into the details of these one. Next case, please. Next slide. Next slide. Next slide. So I think we missed adenoitis, a case of adenoitis. In case of adenoitis, what happens is the child has fever, the child has failure to thrive. This is a very important point. Can you go up, please? Up. I think we missed a case of adenoiditis. Adenoiditis is a very important upper respiratory infection where the child has difficulty in breathing, has mouth breathing, halitosis, and the child has failure to thrive. This adenoiditis leads to repeated upper respiratory infections, including a pharyngitis, tonsillitis, and OAM. So these are the indications for adenoidectomy. Chronic mouth breathing, obstructive sleep apnea, chronic adenoiditis, chronic sinusitis, recurrent acute otitis media. There can be a conservative management like breathing exercises, nasal decongestions, antihistamines, and intranasal corticosteroids. These international steroids act as a bridge over therapy before surgery. Most commonly used drug is mometasone or a fluticasone spray. One spray in each nostril twice a day for 3 months with a gap of 2 weeks between 3 months. It reduces the size of adenoids and relieves obstruction. And if the antibiotics are required, if there is associated acute bacterial tonsillitis in case of an adenitis. This is the antibiotic treatment protocol for adenitis or adenitis. These are the antibiotics. You can use penicillin, benzathine, penicillin, amoxicillin, and so on. So these are the cases most commonly occurring upper respiratory infections. Take-home message is one should try to differentiate between a viral and a bacterial illness, and one should try to avoid antibiotics unless indicated, and one should try to differentiate between upper respiratory and lower respiratory infection. So take-home message, if there is as a criteria should be used to diagnose pharyngotonsillitis, and antibiotics should be prescribed only if there is a score of more than 4. And indicators for AOM include fever, pain, ear discharge, and tympanic membrane findings. In croup, there is a triad of barking cough, stridor, and suprasternal retractions. Epiglottitis, the child has fever and a bending forward position, difficulty in swallowing. Acute tonsillitis, both tonsils are enlarged with multiple pus excretes and tender jugular diagnostic lymph nodes. In chronic tonsillitis, there are non-tender lymph nodes with various degrees of enlargement. In adenoitis, there is chronic snoring and mouth breathing and is failure to thrive. Otitis media, presence of fluid in middle ear, in the absence of an acute infection or a flu. So as I said, the ultimate goal is to can you slow the slide on aware? Yeah. This is a very important slide. The WHO recommends use of antibiotics only if needed, which when they live on a protocol called aware protocol. A indicates the antibiotics which can be used or which are accessible and which can be used with a single consultation. Like I can use an antibiotic when I think it's important. And watch is an antibiotic that can be prescribed with a consultation with other consultant. I need to take a consultation of other consultant if I want to start that antibiotic. And reserve is antibiotics that are generally not used and that should be reserved only if you're suspecting a very resistant organism. And one should try to follow this protocol. Generally, the antibiotics included in aware A group includes amoxicillin, amoxiclav, and first or second generation cephalosporin, ESBLs, and extended spectrum beta lactamases, and other antibiotics should kept in watch. And reserve antibiotics are used only in rare instances when you're suspecting a very resistant organism, and those include linezolid or meropenem. So ultimate message is that try to differentiate between a viral and bacterial URI. Try to limit antibiotic usage as maximum as possible, and try to differentiate between a LRI and URI. So these were the upper respiratory infections, common upper respiratory infections that we come across, and how to identify and how to treat and when to use antibiotics. A brief introduction regarding bacterial viral pneumonia, because as I said, lower respiratory infection itself is a very big chapter. It could be a parenchymal illness of the lower airway. It could be a airway disease of the lower airway, or it could be a interstitial illness of the lung. So most of the time, it's a viral etiology in less than 3 months, 3 months to 5 years. It's a viral etiology. More than 5 years, bacterial etiology, and again, atypical infections been common in more above 5 years. So less than 2 years, mostly respiratory syncytial virus or influenza, parainfluenza, and non-polio enterovirus. Bacterial is 2 to 5 years. Viral infection more than bacterial, but streptococcus, staphylococcus, haemophilus influenza predominate. And more than 5 years, it's a bacterial infections associated with atypical infections. How to differentiate between a bacterial infection and a viral infection? with respect to a lower respiratory disease. Generally, bacterial infections are sudden in onset, whereas a viral infection is gradual in onset. Fever is very high and persistent in bacterial infection, which is low and moderate in viral infection. The child is very toxic in a bacterial infection or is very playful and active in a viral infection between the intercurrent illness. If cough, if present, is dry in a viral infection or dry hacking cough, and if the child is more than 5 years, a purulent or productive cough in bacterial infection. Wheeze is generally of a viral infection, which is not seen in bacterial infection. Examination findings: if there are crepitations localized to a specific lobe, it could indicate a bacterial infection. Diffuse crepitations, more of wheeze, is in viral infection. Breath sounds are bronchial breath sounds in a bacterial infection, which are vesicular in a viral infection. On percussion, because there is consolidation, loss of airways, loss of air being consolidated with fluid or inflammatory X-ray, this dull percussion note, a normal note in a viral infection. There can be respiratory embarrassment or distress in case of bacterial infection, very mild illness in viral infections, unless and until complicated by a secondary bacterial infection in viral illness. Chest X-ray patterns: bacterial can be lobar, there can be air program, there can be a cavity, there can be a pneumonic effusion in bacterial infection, or a complication like a pleural effusion. In viral, generally it is the interstitium that is involved, and it is a diffuse involvement when compared to the bacterial infection. As you see, these are chest X-ray patterns. There's a lobar consolidation on the left side with air bronchogram, and viral pattern, interstitial pattern, where there is hyperinflation and perihilar infiltrates. Then again, you have a lobar involvement and a viral pneumonia where there is an interstitial involvement with hyperinflation. This is a separate class as such. We'll try to take one class on pneumonias. Here the complications of bacterial pneumonia. It can lead to a pleural effusion, it can lead to a cavity, and it can lead to a pneumatocyl when infiltrating a airway below. How to differentiate? Bacterial infections are associated with increased neutrophil counts, CRP being high, and a procal being high, and blood culture may be positive. Total leukocyte can be normal in viral infection. CRP is not elevated, procal can be normal, and blood cultures generally are negative. So previously there used to be 4 classes of classification for pneumonia. Now there are only 2 classes: pneumonia and very severe pneumonia. Pneumonia is can change. Pneumonia is fast breathing and or chest indrawing, and very severe is pneumonia with danger signs. So what are the danger signs? Danger signs include grunt, unable to drink, persistent vomiting, convulsions, lethargy, cyanosis, apneic spells, and narrow pulse pressure. So previously there were 4 classes, now only 2 classes of pneumonia: pneumonia and severe pneumonia. Pneumonia is fast breathing and or chest indrawing, and severe pneumonia is pneumonia with danger signs. Danger signs being grunting, unable to drink, vomiting, convulsions, lethargy, cyanosis. Treatment: viral pneumonia, no antibiotics, supportive care is all that is needed, and oxygen if the saturations are not maintained, and if there is wheeze, a mild bronchodilator. Treatment for bacterial pneumonia depending on whether it's a bacterial pneumonia, whether it's a fungal pneumonia, parasitic pneumonia, whether it's a lobar pneumonia, immunocompromised child or immunocompetent child, depending on the status, all these things, we will start off an antibiotic depending on the suspicion of the organism. If it is a community-acquired pneumonia, if it is a hospital-acquired pneumonia, if it is immunocompromised child or immunocompetent child, depending on that, we'll start an antibiotic. So I think Kankshita, you can go on with the quiz. This was a very brief introduction to a lower respiratory infection. This is a very big chapter, as I said. We'll try to discuss it in a different class. This ends my presentation. Thank you for your patient listening. Any questions, I'll take it. Any questions, you can type in the chat box or you can directly ask. Thank you then.
Thank you, sir.
Hey guys, now that we have decoded the key concepts of URTI and LRTI with such an insightful lecture, it's time to put that knowledge into action. This quiz isn't about testing memory, it's about sharpening clinical thinking, recognizing patterns, and applying what you have just learned to real life scenarios. So stay alert, think like a clinician, and trust your instincts. Let's make this very interactive, engaging, and fun. Get ready to participate because every question is a chance to learn something new. So, guys, let's start our quiz with the first question. The following X ray image is seen in option A COPD, B croup, C bronchitis, and D pneumonia. Please answer in the chat box, guys. Yes, the answer is B, croup. Everyone answered it quite well. Now let's go with the second question. The following X-ray image is seen in option A, thumb sign epiglottitis, option B, steeple sign epiglottitis, option C, thumb sign croup, option D, steeple sign croup. Yes, guys, the answer is option A, thumb sign epiglottitis. Now let's go to the third question. Treatment of a viral pneumonia includes all except option A, bronchodilator therapy, option B, supportive care only, option C, oxygen if oxygen saturation is less than 94%, and option D, antibiotic therapy. Option D, that's the correct answer. Now let's go to question 4. So, which findings suggest pharyngitis and adds to Meckel's score is the question. And we have options as oral ulcers, option B, tonsillar exudates, option C, runny nose, option D, sneeze. Very right, everybody. It's option B, tonsillar exudates. Now let's go to question 5. Name the sign shown in the given X-ray. Option A, halo sign. Option B, deep sulcus sign. Option C, candle dripping sign. Option D, 8 bronchogram. Keep it up, guys. That's the correct answer. Option C, candle dripping sign. Now the sixth question goes. So which of the clinical feature we scored +1 in Meckel's score? Option A, cough. Option B, conjunctivitis. Option C, tender anterior cervical lymphadenopathy. Option D, hoarseness. I think everyone has mastered what Sir said, and that's the right answer. Option C, tender anterior cervical lymphadenopathy. Now let's go to the next question. Seventh question. Antibiotic of choice in pneumonia caused by Staphylococcus aureus. Methicillin-resistant Staphylococcus aureus. Option A, amoxicillin, B, ceftriaxone, option C, cloxacillin, and option D, azithromycin. So the right answer to this question is option C, cloxacillin. Next, we have a short clinical case scenario, which goes like this. A 7-year-old child is brought to OPD with clinical features of high-grade fever, sore throat, and pain during swallowing. On examination, tonsillar exudate with palatal PTK is noticed. What is the most probable diagnosis of the given condition? Option A, pharyngitis, option B, adenoiditis, and option C, dengue, option D, epiglottitis. Yes, everybody, you all are right. Answer is option A, pharyngitis. The next question. Persistence of symptoms beyond how many days suggests a bacterial sinusitis? Option A, 3 days, option B, 5 days, option C, 7 days, option D, 10 days. Guys, most of you all are correct. It's option D, 10 days. So we have the next question, the 10th one. Which of the following is incorrect regarding the indications of tonsillectomy? Option A, 7 episodes in 1 year. Option B, 5 episodes in 2 years. Option C, 5 episodes in 1 year. Option D, 3 episodes in 3 years. Okay, guys, the answer is B, 5 episodes in 2 years. Sorry. No, once get back. Sorry, option is C, 5 episodes in 1 year. Uh, yeah. We have indications for tonsillectomy as 7 episodes in 1 year, or 5 episodes in 2 year, or 3 episodes in 3 years in every year. So the incorrect one here is 5 episodes in 1 year. So it's option C. Now let's go to the next question. Okay. Which symptom is more common both in URTI and LRTI? Option A, productive cough. Option B, shortness of breath. Option C, rhinorrhea. Option D, cyanosis. The correct answer here is option C, rhinorrhea. Now we have the last question of our quiz. 12th one. What is the complication of group A hemolytic streptococcal tonsillitis? Option A, rheumatic fever. Option B, glomerulonephritis. Option C, both A and B. And option D, none of the above. Yes, guys, most of you are right. It's option C, both A, rheumatic fever and glomerulonephritis.
Okay, so hello everyone, I'm Himansh. So this what makes this webinar special from just another lecture is the research insights. So next slide. So the recent PubMed study 2021 says lactobacillus and other probiotic supplementation has a beneficial effects over symptoms of URTI. In terms of reduction in duration severity of fever, it is also associated in improving the symptoms of acute otitis media and probiotics. Uh, okay, it is also advised that probiotics should be treated as an adjuvant therapy, not a replacement of whole standard care like antibiotic therapy and anti-allergic therapy. So, next slide. Another research says saline irrigation, a simple technique, can help you relieve symptoms by clearing mucus and reduce symptoms, and it also shortens illness duration, also congestion. And this is not used by many of Indians, so it is advised to train general public about saline irrigation. Next. And nirsevimab, a long-acting monoclonal antibody, which is special among recent updates, is shown to protect against respiratory syncytial virus, which is more endemic to Telangana and prevalent during monsoon. So it is advised that it is advised all the doctors to stay vigilant during rainy season, that is from August to January, and such passive immunization strategies helps in preventing RSV diseases in infants, and RSV mostly targets children, infants less than 6 months. Next. And antibiotic stewardship. This point has been emphasized for the past few years. So it says it asks us, it envisages a better antibiotic prescribing principles and also reducing unnecessary antibiotic usage. This helps in reducing the superbugs, that is, the multi-drug resistant organisms, and unnecessary healthcare utilization and expenditure. Next. And coming to the last update, this is the simplest and most advisable. Um, that includes hydration and age-appropriate antibiotics, and also nasal irrigation, as we have discussed. So, yeah, now Amita will brief us about all the take-home points.
So after this, we come to the last segment, that is myth busting. The Google form that most of y'all have filled. Let's check how many of y'all have guessed it right. So the first question, am I audible?
Yes, you're audible. Amita, you're audible.
Yes. So the first one, children under 5 years get more severe respiratory infections than adults. Yes, as most of you guessed it right, it is true because of their immature immunity. Second one, green or yellow sputum confirms bacterial infection. This has got an interesting 50-50 response. To conclude, this is a myth. Green or yellow sputum means neutrophilic inflammation, the inflammatory cells shedding out. So a viral infection also in the later stages may present with green or yellow sputum. Wheezing always means asthma. Yes, this is a myth because, as all of you have guessed, almost all, in infants and younger children, many other viral infections also may cause bees. Next question. Steam inhalation cures respiratory infections in children. Yes, this is a myth, just like the majority have said. It relieves symptoms but does not cure the infection. Oxygen saturation below 90% is an indication for hospital admission. Okay, so for those of y'all who are in dilemma, yes, below 90 is an indication because above 95 is what is normal, and especially in children, below 90 is an immediate indication because.
Can I add one point?
Yes, sir.
Don't. One should not treat up to 90%. It is 94, which is a cutoff. So if it is below 94, that itself indicates that the child is in hypoxia, and one should start off oxygen. So 94 is a cutoff. Yeah, that's it.
Okay, sir. Next question. Antibiotics don't help children recover faster from colds. This has also got a 50-50 response. This is real because colds the most generally have a viral etiology, and antibiotics do not have any role for that. Stronger antibiotics work faster. This is a myth. Appropriate antibiotics work. It is not stronger or weaker antibiotics. Next is breastfed babies are less likely to get severe infections. Yes, as all of you have answered, yes, this is true because of the passive immunity from breast milk. Applying balm on chest cures infection. Yes, this is a myth, 100% correct. It just relieves symptoms and cures and gives comfort, but doesn't cure. Next one, if fever comes down, antibiotics are definitely working. Well, this is also a myth because fever may come down really because of antipyretics also, does not definitely mean antibiotics are working. Next question. Milk and curd worsen cough and should be stopped. This is a major misconception in especially our Indian households. So to clear it out, this is a myth. Milk and curd do not have any role in worsening cough. The last one, oxygen inhalation causes dependence. This is also a myth. Oxygen can be stopped safely once the saturation reaches normal values. So it does not cause any dependence. So yeah, almost all of you all have answered many of the questions correctly. Coming back, what is not recommended in respiratory tract infections is for young children is routine use of antihistamines and decongestant combinations because they have potential side effects in younger children. And the key takeaways from what Himansh has already discussed is focus on supportive care like hydration, antipyretics, nasal saline irrigations, probiotics, and passive immunization strategies, and avoid unnecessary antibiotics. On behalf, I hope this becomes the end of the webinar, and I hope we made it as interactive as possible. And I also hope that this webinar has been useful to all the students that have joined. And on behalf of our entire team, I thank you all for patiently listening, joining us, and making this webinar a success. Thank you very much.
Sir, a couple of questions we have from the chat box.
Yes.
How to manage nasal congestion in less than 2-year-olds?
You can install nasal drops. That will suffice. Not more than that. Some practice suctioning with a small bulb like mucus sucker, but it's a cumbersome process. Not everyone is well versed with that. What you can do is just installation of saline nasal drops, 3% saline nasal drops.
No decongestants at all are
No
advised.
decongestants. No. That will lead to rhinitis medicamentosa. Those do have again phenylephrine, which is a vasoconstrictive agent that can lead to damage to the mucosa. So it is the saline nasal drops. What happens is generally with or without medication, it will subside by 5 to 7 days. One should try avoid. No, not try avoid. One should avoid giving any decongestions.
Okay, sir. Sir, one person also asked like if you could explain the quiz questions.
So there are many questions that I don't think time will allow us.
I think there are a couple of them like they didn't answer. Maybe like we can take away on
one or
that.
two.
One is the McIsaac criteria,
Okay.
and the other one was tonsillectomy indications.
One second. McIsaac criteria. It is a criteria in case of it is used only for a group B streptococcal infection pharyngitis. If you are suspecting a group B streptococcal and whether to start an antibiotic or not. What do we specifically want? I didn't get it.
I think people just forgot the criteria. That's all, sir.
Yeah, you can project the PPT, right? I mean, you can show the slide.
Yeah. Amita, can you share this?
I'm sharing this.
Another one was the antibiotic of choice in pneumonia caused by methicillin-resistant Staph aureus.
MRSA can be treated with vancomycin. What you told, what the question was,
cloxacillin,
MSSA.
MSSA.
No, you told MSSA. When it is sensitive, we can use simple amoxiclav, we can use cloxacillin.
Okay. If it is resistant, then... we go for vancomycin.
It was MSSA. What you told was MRSA. While reading out,
okay, sir. Yeah.
You told MRSA. So MRSA, there is no doubt it is vancomycin. This is an antibiotic of choice. MSSA, you can go go with amoxiclav as well. You can go with cloxacillin. You can also go with clindamycin.
What is the empirical antibiotic that can be safely used until the culture sensitivity report is back? We have another question, sir.
Look, it depends on whether the child is immunocompetent or immunosuppressed. It depends on whether the child is in a community setting or the child is in a hospitalization setting. It also depends on whether it is a outbreak or it is a isolated infection. If it is a community acquired infection, the child has a good immunity and is thriving well. Simple amoxicillin, oral amoxicillin would suffice. Okay, simple amoxicillin would suffice. That means we are targeting a community acquired infection where we are targeting a streptococcus pneumoniae or a Haemophilus influenzae. If the child is immunocompromised, the child is in hospital, it is an outbreak of certain infection, one can start off empirically with amoxiclav. If there is no response within 48 hours, they can go on to a cephalosporin. If there is no response, again within 2 days, they can go into an ESBL extended spectrum beta lactamase. And if there is no response, one can always go with suspecting MRSA, vancomycin or clindamycin, vancomycin. So it doesn't depend. Empirical treatment always also depends on whether it is a hospitalized state or it's a community acquired state, the immunization status and severity one cannot access, but whether it is an outbreak or is it an isolated infection. Generally, what we see is a community acquired infections. If it is a hospitalized child, one should always go with a ESBL directly, thinking in terms of a pseudomonas.
So we can follow the AWARE protocol that you mentioned.
Yeah. Then if it is a immunocompromised child and he is in hospital setting with being intubated or ventilated with the airways connected, one should always suspect a resistant organism. We can go with MRSA, drug of choice being vancomycin with a meropenem added, or you can also start off with linezolid as well.
Okay. So one last question. This sputum question being yellow to green colored sputum being bacterial was like 50-50 in the mids and bus. Like you gave the explanation before. Like,
Yeah.
can you elaborate on that?
So look, if you want to differentiate between depending on the color, if it is a viral or bacterial, there are always other symptoms that are present with respect to viral infection and bacterial infection. If you're, but it doesn't always mean that yellow color doesn't always mean it's a bacterial infection. As I think Amrita rightly explained, in later stages, it can be, or when there is inflammatory exudate is more, it can be yellowish. So it doesn't always mean bacterial infection. If you're suspecting, if you want to differentiate, then look into other features like the type of fever, whether the child is well between the intercurrent illness, whether there is a rash, whether there is conjunctivitis, which indicates that it could be a viral infection. Else, if the child is very sick looking, there are no other systemic features, the child is toxic, there is a pleural discharge, it indicates it's a bacterial infection. Don't go only with the color, try to concentrate on other clinical features as well.
Okay, sir. That's all. Thank you, sir.
Last point I want to mention, it is the vaccination or immunization, which is very important, starting from your birth till the whether it be IAP schedule or national immunization schedule. Try to encourage the parents to get vaccinated or the child to get vaccinated or immunized, because government of India is providing most of the vaccines now, whether it be pentavalent PCV, whether it be flu. Apart from flu, most of the times the measles, MMR, all these vaccines prevent this both LRS and URS. So try encourage for the vaccination of the children. Thank you all, Mission Brain India, the participants as well. Still, if there are any questions, please do let me know. You can share my number, let them ask me.
Sure, sir.
Thank you.
You can all leave the meeting, guys. all the participants, you can leave the meeting. Thank you all. Please fill the feedback form also.
Very well organized. Thank you. I too learned a lot. It is a two-way teaching always for me. I will also learn concurrently. Very well organized. My PPT is too good. I mean, the other parts with your introduction part and the quiz and everything, it's too good. Nice. Congratulate each one of you. Carry on with the good work, and please do let me know if there is any other program being planned for next month. I'll try to take the lower respiratory pneumonia specifically if given a
Yeah.
chance.
Sure, sir, definitely, sir. If not webinar, we can try to do a podcast or any other form of lecture series like that.
Okay.
Let's continue with the LRTI also sometimes, sir.
Yeah. Next, if you're going with it, it should be an LRTA pneumonia.
Yeah.
So thank you so much, sir. We are
Thank you. Thank you.
really
Not
grateful
not
to
an
have
issue. Thank
student-friendly
you,
faculty
people
like
as
you.
well.
Sir, can you please stay back, sir? The
Oh yeah, sure.
organization needs a picket since
Hmm.
actually
Okay.
I'll stop recording.